Opinions, options, answers. Voice America Health and Wellness.
Welcome to Psychiatry, Ask the Expert, hosted by Dr. Neil Kaye. All comments, views, and opinions expressed are solely those of the host, guests, and callers. Dr. Kaye will not diagnose or treat callers. The information provided is informational in nature. In the next hour, Dr. Kaye explores the inner workings of the brain and mind. Grab a pen and paper and sit back. Here is your host, Dr. Neil Kaye.
Good evening and welcome to Psychiatry Ask the Expert. I'm Dr. Neil Kaye, my co-host Jay Birch, and I want to welcome you all to our show today.
Neil, how are you doing this evening?
Having a great week so far. It's going to be a great show tonight. I'm really excited.
Hello to all our audience out there.
Absolutely. Welcome back. Each week on Psychiatry Ask the Expert, we focus on a specific topic in psychiatry. We talk about the disease or illness itself, the common symptoms and presentation of the illness, and, of course, treatment options with a focus on psychopharmacology, the medication treatments. We talk about potential risks and benefits, side effects, dosing, when and how to use the best medications. Tonight, Jay and I are very honored and pleased to have a close friend and esteemed colleague, Dr. Lee Cohen, with us tonight. Dr. Cohen is an associate professor of psychiatry at Harvard Medical School and the director of the Perinatal and Reproductive Psychiatry Research Program at the Massachusetts General Hospital in Boston, Massachusetts. Tonight we're going to be talking about women's issues in mental health, including the longitudinal course and treatment of psychiatric illness in women, pregnancy, the postpartum period. We're going to talk about the effects of failure to treat anxiety and depression on a developing fetus, the risk of medications during fetal growth and development, and we'll also talk about peri and postmenopausal depression and its treatment. So we're going to try to cover all of women's mental health in 1 hour if we can.
Tonight's show is, what, 2 hours?
We're going to rock tonight without a doubt. So welcome, Dr. Cohen. If you're out there, say hello to our audience.
Well, thanks for inviting me, Neil and Jay. It's really a pleasure to be here this evening.
Okay, listeners tonight, you can call in with questions or comments at any time. Our call-in number tonight, 866-472-5792.
Neil, why don't we go to our On My Radar segment? What's on your radar this week?
Just a short list tonight because I won't have time for Dr. Cohen. Increase in methamphetamine use, sweeping the country, moving from west to east. It's finally gotten to the East Coast. So for listeners and parents, you want to be aware, methamphetamine use on the rise, basically speed, and this is going to be a big problem. Second one, vitamin B fails to prevent heart attacks. We all wanted this one to work natural, healthy. I mean, what could be better than a vitamin? And yet the newest, biggest studies show it doesn't really do what we all thought it did. Again, you have to get the evidence base in order to really answer the questions. How about your radar screen, Jay?
Well, Neil, one of my favorite health journals, Forbes magazine this week, has an article entitled Sharp as a Tack. And it's about aging minds can be made young again. It's a very interesting concept. The story is about a professor of neuroscience at the University of California at San Francisco by the name of Michael Mersenich. If your name is pronounced incorrectly there. But he's been doing electrophysiology studies of the brain for about 35 years. And he's recently come up with now software which is essentially brain fitness software. It's designed to maintain or increase the plasticity of the brain. And, you know, it's thought that the loss of plasticity as we age contributes to the onset of Alzheimer's disease. So what Mr. Mersenich's software essentially is going to do or supposed to do is to rejuvenate or increase the plasticity, make young again an aging brain. And obviously, a lot of hopes out there attached to this because of the nature and the incidence of Alzheimer's disease with our aging population. But just, again, something where we're constantly looking for hope, and this lies outside the realm of psychopharmacology. What do you think?
Well, it does. And this issue of exercising the brain, much like muscles, use it or lose it. If we can keep stimulating our brains, maybe we will be less likely to develop Alzheimer's or have aging. I think it's a great idea, great concept, something we all recommend to patients. Unfortunately, the science behind it and whether or not it really works is questionable. but it has no downside effects, so there's no reason not to do it. It makes me think about the effect of hormones in aging and memory and depression, and we're going to be talking with Dr. Cohen tonight about those. So let's go right to Dr. Cohen and start with some questions about psychiatric illnesses, mental health issues in women. Lee, what are some of the differences between men and women when it comes to the presentation of common disorders like depression and anxiety?
Well, it's really a critical question that has been looked at systematically probably for the last decade or so, which in a way is a bit of a surprise because we have information about other types of medical illnesses, going back many, many years. But it's really only in the last 10 years that there's been increasing interest in so-called gender-based medicine or gender-based differences in terms of how frequently we see illnesses, differences in how often we see those illnesses between men and women, differences in terms of the symptoms, for example, with depression that we might see between men and women. And then lastly, there's been great interest in the last several years in gender-based differences in response to, for example, antidepressants. And so when we think about depression, just as an example, we know that depression is about 2 times more common in women than in men. And that's a finding that is very well established from very carefully done epidemiologic studies. And the data are consistent that for reasons that I don't think are entirely clear, it appears that women are at increased risk for depression compared to men.
Okay. What about things like anxiety and bipolar disorder? Do they present differently?
Well, first, in terms of their frequency, we know that anxiety disorders like depression are more common in women than in men. And bipolar disorder, or what's frequently referred as manic depressive illness, I think in the general population, the community, is about roughly equal in men and women. But going to your question in terms of, for example, do women with depression, do they present differently? Do they have symptoms that are different than men? And the answer actually is yes. For example, where men may have impairment in sleep and not sleep well, or have a dramatic decrease in appetite, we frequently see in women that they actually have increased sleep, that their need for sleep increases, and that actually appetite increases. So there are actually differences in symptom presentation. We actually see more anxiety kind of mingling with depression in women compared to men. And so as we kind of evaluate women and men, we have to kind of have that in mind because how patients present really may be different based on gender.
Lee, you said that there isn't really an agreed-upon reason for these differences, but would you care to speculate or theorize? Are women processing their environment differently? Are they reacting to stimuli differently than men? What do you think's going on here?
Well, I don't think that there is a single factor that drives the increased risk for depression, for example, in women compared to men. And although there are very good scientific data supporting an intricate relationship between female reproductive hormones, for example, and the effects of those hormones on the brain as compared to what we see in men, we really don't have data suggesting that it's the female reproductive hormones that are somehow responsible for depression. There's other literature that suggests that there may be psychosocial factors that are involved, that the stresses experienced by women may be, in fact, different than men, and that may drive the risk. There are even reports that suggest that as we measure depression in women compared to men, that there may be what we call a reporting bias, that women may be more forthcoming with and more willing to disclose symptoms of depression than men, and perhaps that accounts for some of the difference in terms of the frequency with which we see depression in women as compared to men. And I think at the end of the day, as we go forward and do more and more sophisticated research, what we'll see is that gender-based differences in risk for depression between men and women probably derive from multiple factors. It's probably partly differences in neurobiology. We know that the female brain is indeed different than the male brain, even at the anatomic level. We'll see that there may be effects that are driven by differences in the reproductive hormonal environment that we see in women compared to men. There may be certain psychosocial factors, and that, again, there's kind of a commingling or a meshing of these factors that ultimately lead to this very consistent, very systematically derived observation that women are at increased risk for depression.
I want you to spend just a couple minutes, if you can, on PMS, because we tend to say with women, hormones are always the answer. It's got to be something wrong with the hormones. They got too much, they got too little, and hormones for a couple centuries have been blamed for everything. Is PMS really a hormonal issue, and do hormones really do anything to treat this, or is it something else?
The question of hormones and the extent to which they drive psychiatric illness, whether it be PMS or other problems, it's gotten a lot of attention in the lay press. It really turns out, and I think it's an important kind of message for the public, which is that there are really very little scientific data to suggest that differences, for example, in hormones cause a certain psychiatric problem, whether it be PMS or depression. It may have some role, but in terms of, for example, too much or too little, whether it be PMS or perhaps even better studied has been postpartum depression, it's really not about too much or too little reproductive hormone. In a way, it's just far too simplistic a model, and I just don't think we're at a point where we understand precisely what is responsible, what underlies symptoms, for example, of PMS, but it's not as if we can just kind of throw hormones at these problems and assume that patients are going to respond.
In fact, I think the data shows that hormonal treatment for PMS is not very effective, whereas serotonin reuptake inhibitors are much more effective. Is that reasonable?
Well, we certainly have many studies historically that looked, for example, at the use of hormones, particularly oral contraceptives, for the treatment of PMS or more severe PMS, which we call premenstrual dysphoric disorder, or PMDD. And the majority of those early studies were pretty disappointing. And I think in 2006, it's safe to say that we have very extensive data regarding, for example, the newer antidepressants, the selective serotonergic reuptake inhibitors, the SSRIs, in the treatment of severe PMS or PMDD. But, Neil, there's actually been several recent studies that have kind of looked a little bit more systematically at certain types of oral contraceptives or hormone treatments for PMS, which have actually been very encouraging.
We hold that thought, and we'll come back to that right after our break.
But before we're going to be going to break, actually, I want to encourage the women out there in the audience to give us some calls. The one thing is we've got 3 men here tonight discussing women's issues. We need some women input, so give us a call, please. We're going to go to break.
Real Life Solutions. Voice America Health and Wellness.
To perform at your maximum potential, you need to have all aspects of your life working properly. On Mind, Brain, and Body, Dr. Michael John Kell will bring you honest, open discussions concerning your physical, mental, and financial health. If you're ready to find purpose and meaning in your life, tune in to Mind, Brain, and Body every Friday at 8 a.m. Pacific. Mind, Brain, and Body on Voice America Health and Wellness. Radio dedicated to your health, wealth, wisdom, and purpose.
Videos de aprendizaje de inglés. Máxima calidad.
Nunca escucharás a alguien vendiendo educación en la calle, pero con programas familiares gratuitos sí puedes obtener la educación que necesitas. Llame al 1-877-326-5481 para información sobre programas gratuitos de educación familiar.
Mira, vengan aquí. Obtengo un mejor vocabulario en inglés garantizado.
El primer paso a una vida mejor. Un mensaje del National Center for Family Literacy y el Ad Council.
Achieve exceptional levels of health and fitness through integrating the very best in fitness, nutrition, and healing. Tune into Total Fitness with fitness, nutrition, and healing coaches Katherine Kerrigan and James Williams. Each week, get inspired to exercise, eat and rest in harmony with your body's needs, and take advantage of effective natural healing methods with in-depth cutting-edge information and advice. Get fit, get healthy, get motivated, and get real with Total Fitness, broadcasting every Friday at 7 a.m. on Voice America Health and Wellness.
Are you tired of being tired? Are you sick of sitting around while life passes you by? You can get back on track by tuning in to Voice America Health and Wellness every Monday at 12 p.m. Pacific Time for Attracting Abundance, the Energy of Success with Carol Look. Attracting Abundance is the program that empowers you to finally break through your limiting beliefs and blocks and shows you how to succeed in all areas of your life, from improved financial abundance, health and weight problems, as well as your relationships. Don't wait another week to be joyful. Listen to Attracting Abundance, the Energy of Success with Carol Look, this Monday at 12 p.m. Pacific Time, right here on Voice America Health and Wellness.
Parents, did you know that high school dropouts make 42% less than graduates? Someone will have to make up that difference, and chances are that will be you. That means paying 42% of their groceries.
Ooh, more candy.
42% of their dentist bills.
No more candy.
Even 42% of their therapy sessions.
It's all my dad's fault.
Save your money. Encourage your kids to stay in school. For help and advice, call 877-FORAKID. A message from the U.S. Army and the Ad Council.
A fresh look at today's health. Voice America Health and Wellness.
Welcome back to Psychiatry, Ask the Expert. If you have a question or comment, dial toll-free at 1-866-369-3742. Now back to the show. Here's Dr. Kaye.
Welcome back to Psychiatry, Ask the Expert with Dr. Kaye. Actually, we're going to continue with Dr. Cohen, but we've got a caller on the line. We've got Joanne from Washington. Joanne, good evening. Can you hear us?
Yes.
You want to give your question, if you would, for Dr. Cohen?
My family, the women do have a problem as they age.
I need you to speak up. Just a little bit.
Sorry, my family with aging, the women do have a problem with depression. Is there something that I could do besides medications or suggestions on maybe what I could do? I'm worried about it because it is genetic.
Okay, so we've got a family history of aging in the women. Are there alternatives besides psychopharmacology, things she should look for or be doing herself? Lee, you got some answers for us?
Well, I think that, the caller raises two very interesting kind of points by way of her questions. The first is, what is the risk for depression as women, and actually men for that matter, but as patients get older? And I think that it highlights from a public health point of view the fact that depression as patients get older is frequently underdiagnosed. Now, there is a literature that suggests that for some women, as they, for example, make the transition to the menopause, and when we talk about menopause, we're talking about that period of time when menstrual cycle function becomes less regular, patients may be getting hot flushes and night sweats, that as women get older, there may in fact be an increased risk for not just depressive symptoms, but major depression. And actually, several groups have suggested that, including our own at Mass General. But I think that women where they look around in their families and there's a strong family history for depression and perhaps later life depression or at certain particular times, it is wise to be kind of aware and vigilant of that as a potential problem in families. And then with respect to treatment, I think that the beauty of psychiatry today is that we have a number of therapies that are effective for managing this very common problem. And yes, of course, we have the antidepressants and the press that antidepressants get, and we know that they're efficacious. But as the caller asked, there are non-pharmacologic interventions such as psychotherapy and even particular types of psychotherapy that may be very helpful for patients who, for either they can't tolerate medicine or they want to perhaps go the non-medicine route as a first pass depending on the severity of depression. And I think, in a way, it's important for patients to realize that it's not one size fits all when it comes to psychiatry or managing psychiatric illness, but really matching patients' problems and their wishes with the available treatment options.
Joanne, it's Jay. Were you asking more along the lines of perhaps something you could do to prevent or delay depression later on in life?
Yeah, or help. If there were some things that I could do as far as like exercise or nutrition, or do you feel that's a factor?
Lee, you want to try any comments about exercise, nutrition, preventative lifestyle issues?
Well, it's interesting. There's been an increasing interest in looking at the role of exercise. In fact, several recent studies that have actually suggested that exercise, either alone or in combination with other lifestyle changes, may be an effective treatment for depression. My concern about that really is that patients, should not, if they start an exercise regimen clearly under the supervision of a physician, in the absence of real improvement, if they're having problems with depression, just can't stop there. And so, whether we're talking about complementary interventions or exercise or other lifestyle changes, that's fine if it works. But it concerns me that many patients may pursue that and get incomplete treatment or have incomplete recovery. And we know that when it comes to depression, incomplete recovery just kind of breeds more and more depression, and it becomes, can become very chronic and problematic for patients.
I think one of the problems that develops also is that there is a great interest in natural products with a belief that they might be safer or more effective or better tolerated. And I think Dr. Cohen and I would both agree that we have nothing against alternative medicine, complementary medicine, natural things, but we want them to undergo the same rigorous, evidence-based science kind of testing. And when that's happened, a lot of times the natural products have not done terribly well. We started tonight's show with a comment on the new study showing that vitamin B did not prevent heart attacks. The evidence for things like St. John's wort and depression have really been pretty weak, and although it looked exciting at first, it simply has not held up well. And I think that regardless of the treatment intervention, whether it's a cognitive behavioral therapy, a vitamin or a supplement, or a pharmaceutical, that they all need to undergo the same testing before we recommend them to patients with the certainty that we as scientists should be trying to use. Joanne, you think we covered your question, or do you want to ask a follow-up there?
No, I think you did very well. Thank you.
Great. Thank you for calling in. We appreciate that.
Lee, before we went to the break, you were in the midst of discussing PMS, and you wanted to continue on?
Well, Neil had asked about PMS and premenstrual dysphoric disorder. I think it's very important for patients to know that PMS symptoms are normal. And when we talk about PMS, if you go out into the general population, if you took a sample in the community, 60 to 70% of women will have mild premenstrual symptoms, whether it's a little bit of irritability or anxiety or physical symptoms such as bloating or breast tenderness, and that's really not pathologic. And that's not, when we talk about severe PMS or premenstrual dysphoric disorder, we're really not talking, we're talking about a much more severe level of symptoms that are limited to the latter phase of the menstrual cycle as opposed to the earlier phase of the menstrual cycle. And the reason I wanted to come back to that, Jay, was that in a study that we did at MGH, we looked at women in the community who had the complaint of PMS, and we did a very structured interview that we use in psychiatry to make a diagnosis, and we actually found that patients who identified themselves as having PMS, about 40 to 50% of the time actually did not have premenstrual dysphoric disorder or even PMS, but they actually were suffering from an underlying mild to moderate depression or an anxiety problem. And that's very important information because we have effective treatments for depression and severe PMS, but it's very important that, for example, if a woman has PMS and goes to the health food store but really has depression, it's important that that patient get effective treatment for depression. So when I think about PMS and I hear about patients complaining of PMS, one of the very first things I think about is, yes, it may be PMS limited to the premenstrual phase of the menstrual cycle, but it may really be an underlying problem with mood or anxiety.
Lee, I want to follow up and maybe tie into our caller Joanne's question. There's a young lady who is looking at her female relatives in her family. She's saying there's some increased incidence of depression later in life. Is there any epidemiologic evidence that women who get depressed later in life had PMS earlier in their life, or maybe had milder depressive episodes that weren't detected?
That's such a neat question, and if I was to kind of reframe that a little bit, it's almost women who have been vulnerable to depression, particularly around periods of reproductive hormonal change, such as when women are premenstrual. Does it put them at risk, for example, later on when they're postpartum or when they're transitioning, for example, to the menopause? And there actually are data that would suggest that some women who appear to demonstrate, for example, depressive symptoms around these periods of reproductive hormonal change may be vulnerable over time to return of those symptoms at other times of reproductive hormonal change. And from Joanne's call, I wasn't sure whether she was talking about women in her family who became specifically depressed during that transition to the menopause, but it's very common when we're in clinic, in our menopause clinic, and we see patients who are presenting with either return of depression in the menopause or new onset of depression, to actually tell us that they've had problems with depression, in the past, or depressive symptoms when they may have had PMS earlier on in their lives, or they may have had postpartum depression.
Is perimenopausal or postmenopausal depression on the rise? I have to say, I am seeing a lot of women as they're aging in their late 60s, early 70s, presenting with depression. A lot of them don't want to admit it. It's shameful to them. It's different than what they think they should have, but it certainly seems to be on the rise in my practice. You get 1 minute to answer this question.
I think that the answer to that question is that I think that there's not so much an increased prevalence per se. I think that the good news is that patients are becoming more aware of depression. There's been attention in the media. There's been attention with various public service types of outreaches, and there's an awareness that depression is treatable. And so I think at the end of the day, we have more patients actually coming to see us because there's greater awareness.
Great. We're going to be going to break, and we're going to return with Dr. Lee Cohen as our guest on Psychiatry Ask the Expert. We're going to focus on the pregnancy and medications in pregnancy issue in the next segment.
Opinions, options, answers. Voice America Health and Wellness.
Stay mentally, physically, and emotionally fit with Younger Every Day. Hosted by Dr. Bob Payson. Broadcast every Friday at 10 a.m. Pacific Time, 1 p.m. Eastern Time on the Voice America Health and Wellness channel. Younger Every Day will offer you alternative solutions for a variety of health issues, all backed by clinical, scientific, and medical data. Dr. Payson and other expert guests will inform and inspire people of all ages to look and feel better. Younger Every Day. Think clear, feel strong, grow younger. With Dr. Bob Payson, right here on Voice America Health and Wellness.
Women, do you feel that you're too old to be active, too old to be beautiful, too old to have fun, or too old to be fabulous? Well, if that's what you think, then there's good news for you. You're wrong. Tune in to Voice America every Wednesday at 8 a.m. Pacific Standard Time for Aging Outside the Box. Fabulous Women Over 50 with Shirley Mitchell. Aging Outside the Box is a fabulous, fun program that gives you every reason to feel greater than you ever have. Host Shirley Mitchell and OE Cruiser Small will cover phenomenal topics such as women's issues, health, diet, exercise, nutrition, faith, travel, and many other concerns for women of all ages. Feel young, feel smart, and feel fabulous by tuning in to Aging Outside the Box. Fabulous Women Over 50 with Shirley Mitchell every Wednesday at 8 a.m. Pacific Standard Time, right here on VoiceAmerica.com.
To perform at your maximum potential, you need to have all aspects of your life working properly. On Mind, Brain, and Body, Dr. Michael John Kell will bring you honest, open discussions concerning your physical, mental, and financial health. If you're ready to find purpose and meaning in your life, tune in to Mind, Brain, and Body every Friday at 8 a.m. Pacific. Mind, Brain, and Body on Voice America Health and Wellness. Radio dedicated to your health, wealth, wisdom, and purpose.
Step into a healthier you. Voice America Health and Wellness.
Welcome back to Psychiatry, Ask the Expert. If you have a question or comment, dial toll-free at 1-866-369-3742. Now back to the show. Here's Dr. Kaye.
Number tonight is actually 866-472-5792. We're with Dr. Cohen, and we're going to go right to the big question. Lee, are psychiatric medications safe in pregnancy? What are your thoughts? What does the literature say? What should the patients be thinking and asking?
Well, we've spent the last 15 to 20 years working with patients to help them make decisions with their doctors about whether they should or should not take psychiatric medications during pregnancy. And we actually have more information regarding psychiatric medication use during pregnancy than we have for probably the majority of medications that women use during pregnancy. And I'm often struck by the great concern about using psychotropics during pregnancy, and sometimes a little bit of a cavalier attitude about exposure to other medications. I mean, at the end of the day, we don't have absolute data going one way or the other regarding almost any medication that women use during pregnancy. And so, as a general rule, women we would have women avoid using psychiatric medications during pregnancy. However, Neil, the problem is that women aren't protected against psychiatric disorders during pregnancy, even though I think that's kind of clinical lore. It turns out to be wrong. And when it comes to problems like depression or anxiety or bipolar illness, manic depressive illness, it turns out that women are just as vulnerable to those illnesses during pregnancy as they are when they're not pregnant. And so it's very important that patients have good information about the various types of medicines that we prescribe in psychiatry, so that with their doctor then they can make decisions about whether they're going to try to stop or not, or perhaps stay on, for example, an antidepressant during pregnancy. So these are very individualized decisions, but they're at least decisions that we can make, I think, today based on the available information regarding these various medicines on one hand, and also the likelihood that that patient will have symptoms during pregnancy on the other.
Now, Tisner, I read that somewhere around 30% of women actually take psychoactive medication during pregnancy. Does that sound about right?
Well, we really don't have great data on exactly the number of women that use psychiatric medications during pregnancy. But actually, the literature, it's an older literature, said about 30 to 40% of women use some psychoactive medication at some point during their pregnancy.
Okay, so it's obviously a pretty common event, and we're always looking for more assurance that we don't always have. Would you talk about the difference of, I think patients frequently assume that the risk is medicine versus no medicine, and don't ever think about the risk of being untreated during pregnancy and what untreated panic attacks or bipolar disorder or OCD, what effect, if any, that has on a developing fetus. So can you talk a little bit about what happens if you don't treat, because I think that's really the appropriate risk that they need to be measuring against?
Well, I think you're right on. We're obviously concerned about the risks of exposing a fetus to psychiatric medications, and we can talk about that a little bit as well. But there's kind of a perception by many patients that better to just kind of white-knuckle it. If a patient has problems with anxiety or depression, better to try to just shake it off or just to kind of get through it and bear with it than to think about various treatments that they might get, including pharmacologic treatments. And the reason that type of, in a way, logic fails is, as your question suggests, there really is this growing literature that says that untreated psychiatric illness during pregnancy can do harm to the fetus and can actually affect the wellness of the mom, can have an effect on, for example, the gestational age, how the number of complications that we may see, for example, during a pregnancy, or rates of early labor, preterm labor. And so the idea is that it's not as if not treating doesn't have its risks. It really does. And we're starting to see that with depression, and we see that in the literature with anxiety disorders. And your reference to women with bipolar disorder is a great example, because women who stop their medicines that are being used to treat bipolar illness frequently pursue types of behaviors that may be very detrimental to pregnancy, such as alcohol use, tobacco use, or just even noncompliance with their prenatal appointments, which is one of the strongest predictors of of the well-being of the child is, did mom make it to prenatal appointments? So I think that the point really is that we're talking not just about exposure to a medicine during pregnancy, but we're really talking about what is the effect of not treating and what is the potential negative effects on pregnancy of untreated disease.
Right now, a lot of women, as you and I know, actually become pregnant unplanned, and they're on meds, and then they suddenly realize, oh my gosh, I'm pregnant and I'm taking medicine, and the knee-jerk reaction by both patients and frankly a lot of physicians is to just instantly, abruptly stop everything. Is that a good move?
Well, we've studied this very carefully in several disorders, and the ones that we can speak to, most clearly are depression and anxiety, major depression, anxiety, and bipolar disorder. And that reflex, although understandable in many respects, it's understandable that the patient and the doctor would want to limit exposure to a psychiatric medication or any medication for that matter. But the data would suggest that if you stop those medicines, that the disorder may return very quickly. For example, with depression, we actually showed in a study that we recently published that across pregnancy, women who stopped, about two-thirds of those women had return of major depression. Panic disorder, very similar results. In bipolar illness, about half of patients had return of pretty significant symptoms by about 12 or 14 weeks, just around the end of the first trimester. And so the point is really well taken. The knee-jerk response to just stop the medicine may actually put mom and fetus at risk, because the risk for return of the illness is very high, and it's actually, very high early on in the pregnancy. So it's not as if the mom is just going to stop and kind of make it through till the end without a difficulty. We actually showed, and others have shown, that the return of the disorder really may be seen very early on in pregnancy after the women have stopped those medicines.
Lee, how about the scenario where the woman is already on psychotropic medication, she becomes pregnant, and obviously through pregnancy her body, size, dimensions change. How likely is it that the dose of the medicine she was on pre-pregnancy is going to continue to be the dose that she needs to be on during her pregnancy?
Such a neat question, because, again, we know that the concentrations of those medicines are falling across pregnancy. And although that's well documented across psychiatric medications, we actually end up not arbitrarily increasing the dose to maintain a certain concentration of medicine, but rather just watch that patient closely, and if she has even evidence of worsening symptoms, then we'll very comfortably increase the dose. Because it's important to keep in mind that, for example, when it comes to risk for organ malformations, there does not appear for certain psychiatric medications, for example, antidepressants, to be a clear dose adverse effect relationship. It's not as if more is worse. And so, again, going back to Neil's early question about the risk of untreated illness, and certainly in our center, we treat to ensure that patients are well during pregnancy. And if we're going to treat already, we don't kind of just use lower doses and get moms kind of well. We really treat with adequate doses to make sure that mom is emotionally well during pregnancy.
Lee, would you care to characterize, if you would, your experience or what you hear your colleagues talk about? What's the patient management relationship between the OBGYN and say, a psychiatrist during a pregnancy and a woman who's obviously on a psychotropic med?
Well, the good news is that I think it's changed a little bit over the last 10 years. I think that the reflex on the part of obstetricians has been, historically just to stop those medicines, and frequently that put women in harm's way. And I think that what we've seen is that with this growing interest in depression and other psychiatric disorders during pregnancy, their course, potential treatment options, I think that we see much more collaboration between OB, psychiatry, and the patient. And it's very important for the patient that she feel that her doctors are really on the same page and that there's kind of a jointly arrived at plan with respect to what they're going to do, whether it be stop or continue a medicine.
All right, before we go to break, I want to try to summarize this segment because there's an awful lot of material here. We want to be careful about the risks. We want to explain them to the patient. We want to make sure our treatment plan is individualized and that some women might be okay to come off, some might need more, some might need less as they go through pregnancy. But we're going to treat these people as individuals and not just make blanket statements about, well, all women need this or don't need that. And I think that that's important. Weighing the risks and benefits, and especially the risk of no treatment, is very important. If you are going to stop medications, they should not be stopped abruptly. They at least should be tapered over some period of time because that actually might reduce the risk of relapse a little bit, even with a relatively short taper. We're going to be going to break. After break, we're going to continue with Dr. Cohen, and we're going to be taking questions. Please, we need some more women to call in with their questions for us, 866-472-5792. We'll see you after the break.
Helping you make informed decisions for your life. This is Voice America Health and Wellness.
Hey, how you doing? Educational videos, top quality, right here.
You'll never hear anyone selling education on the street. But with free family learning programs, you can get the education you need. Call 1-877-FAMLIT1 for information on free learning programs. 1-877-FAMLIT1.
Check it out, check it out. Want your GED right here, guaranteed, ma. Come on, check it out.
Free family learning programs from the National Center for Family Literacy. Brought to you by the National Center for Family Literacy and the Ad Council.
When you combine energy secrets from ancient China and the latest breakthroughs in medicinal science, you get power healing with Dr. Shah. Heard every Friday at 5 p.m. Pacific Time on Voice America Health and Wellness. Each week, Dr. Shah will bring you another step closer to the expanding world of body-space medicine. You will quickly learn and appreciate how power healing is a perfect alternative to hospitals and expensive drugs. Take a step beyond modern medicine every Friday at 5 p.m. Pacific Time with Dr. Shah on Power Healing, right here on Voice America Health and Wellness.
Growing Up in America explores the challenges, risks, benefits, and differences this generation of children face each day. Hosted by veteran pediatric emergency physician and father of 4, Dr. Charles Nozica, this show is for parents, teens, and children. It crosses each generation. By exploring the unique aspects of matriculation within this current generation, we hope to find answers and ways of optimizing this experience for today's generation. Growing Up in America with Dr. Charles Nozica broadcasts each Tuesday at 2 p.m. Pacific, 5 p.m. Eastern on the Voice America Health and Wellness channel.
Opinions, options, answers. Voice America Health and Wellness.
Welcome back to Psychiatry, Ask the Expert. If you have a question or comment, dial toll-free at 1-866-369-3742. Now back to the show. Here's Dr. Kaye.
Welcome back to Psychiatry, Ask the Expert with Dr. Kaye, Dr. Cohen, and Jay Birch. Lee, let's start with lactation, breastfeeding. Any thoughts about medications and breastfeeding for our patients out there?
It's probably one of the most common questions that we get asked at our center, which is that if women are postpartum and are, let's say, being treated for postpartum depression with an antidepressant, can they breastfeed? And the answer to the question is yes, they can. All antidepressants that women take during the postpartum period are secreted into the breast milk, but if you actually measure the amount of medicine that gets through to the infant, if you actually measure the infant's blood, turns out that the concentrations of those medicines are just exceedingly small and, just exceedingly scant. And for women who are motivated to breastfeed, and we clearly know that there are some advantages medically for the infant with respect to breastfeeding, that certainly using probably the vast majority of psychiatric medications that we use is not contraindicated per se during lactation. And as is the case for many other medicines, for example, that women use to treat other illnesses that they take and that they may actually take while breastfeeding.
With breastfeeding, any data on specific compounds that either may be safer or less safe, or just have more data than others?
We probably have the most accumulated data for the antidepressants. And in fact, we have more data for the antidepressants when it comes to lactation than we do for probably almost any other medicine that women take during the postpartum period with respect to lactation. And the extent to which these concentrations of antidepressants have been really studied and quantified in the baby's blood is really extraordinary compared to, for example, medicines that a woman might take for reflux esophagitis during the postpartum period, where we know very little about, for example, how that class of medicine is secreted into breast milk. I guess what concerns me as a clinician is that some patients may defer getting treated for psychiatric problems. A woman may be suffering from postpartum depression, and she may not get treated because she is fearful of taking an antidepressant and breastfeeding. And so when it comes to breastfeeding, I think it really goes hand in hand with the issue of getting adequate treatment for postpartum depression, as an example. Nothing is more important than women getting treated. And if women feel that they don't want even the smallest bit of exposure of the baby to antidepressant, then they should actually defer breastfeeding and get treated for the postpartum depression. And so we see that scenario all the time, and we always feel badly if the woman has waited 8-9 months while she's been breastfeeding, but she's been sick, and then she comes to see us to get treated because she's actually weaning the baby from the breast and is now willing to consider getting antidepressants. It shouldn't be one or the other necessarily.
Leo, I want to interrupt just a second and comment that it's not uncommon to pick up a psychiatry journal, any medical journal, almost any People magazine, Time magazine, Newsweek these days, and have an article related to pregnancy and meds. And I know you do a lot of research, Kim Yonkers, Zach Stowe, Kathleen Wisner. Where can our listeners or even professionals go to? Where's a good reference source of information on this issue?
Well, I think it's very important for women to be able to get user-friendly information, and also for their doctors to be able to get accurate, user-friendly information. We were funded to set up a clearinghouse of information in this area, which is a web-driven resource called womensmentalhealth.org. One word, womensmentalhealth.org. And we started several years ago, and we've just been astounded at the growth of our visitorship, and we keep it very up to date because, Jay, as you mentioned, patients and doctors may go to the literature, but there may be a delay between there being new findings that a patient reads in the newspaper or in Newsweek and them actually appearing in the literature. So patients need good resources, but they also need to know accurate resources, because sometimes it's one thing if you're looking at our website or WebMD, but there's a literature that suggests that maybe as much as 30 to 40% of the information on the Internet is not correct. So I think women have to be very careful, and patients have to be very careful about the sources of information that they're going to rely on to make these kind of very important decisions.
That's great. Lee, I want to shift gears with you and talk about the reluctance of women to take estrogen. There's been a lot of bad press about estrogen, as you know, in the last year or so. Reluctance of women to use estrogen for perimenopausal, postmenopausal symptoms, especially hot flashes and insomnia. Any recommendations, alternatives? Where's all that at?
Well, you're right, Neil. After some of the data were presented, and now multiple publications regarding some of the small but nonetheless real risks of using estrogen, particularly using it more chronically, not necessarily in the short term, but more chronically. There has been many patients who have veered away from the use of estrogen. I think it's very important to keep in mind that the Food and Drug Administration did not tell women in 2002, after the publication of the Women's Health Initiative data, that estrogen should not be used in the short term for the treatment, for example, of hot flushes. But they did say that there were concerns about using it over the long term, and also suggested that estrogen did not protect against heart disease. Now, those studies have been, widely criticized and evaluated, and there are some supporters and some critics. But I think, to your point, there are some women that, regardless, want an alternative to taking estrogen, for example, to treat the vasomotor symptoms or night sweats or hot flushes that we see as women are making the transition to the menopause. And some of the treatments that have been, really demonstrated now to be very effective have been low doses of antidepressants. And there have now been multiple studies, drugs, for example, such as Effexor or Paxil or low doses of Lexapro, have all demonstrated now to be effective in treating symptoms of hot flushes. We've also noticed in some of our own work that it's really kind of a blend of symptoms that bother this population of women as they're making the transition. And so frequently it's a combination of hot flushes, depressed mood, and insomnia. And we find that when we look at quality of life in women as they make the transition, it's really important that we be focusing on mood symptoms, on treatment of hot flushes, as well as managing insomnia, so that we really hit all of those areas and not just one.
Okay, that's really, really helpful. I think the listeners will appreciate that. I'm going to try to summarize some things here and get us wrapped up. And first, I want to make sure I thank you for your time and participation tonight. I'm sure this is going to be a show that gets replayed a lot. What we've agreed here is anxiety and depression are real medical illnesses. We need to take them seriously and make sure that they're not being missed in women who sometimes get underdiagnosed. Certain periods in a woman's life increase the risk of needing professional help. You talked about times when their bodies change, when their hormone levels change, onset of menstruation and getting your period, pregnancy, and then, of course, cessation. And yet at the same time, it's not all about hormones, that there are other transmitters in the brain, other things that change, and a lot of this might have something to do with serotonin levels, and we're using a fair amount of these serotonin reuptake inhibitors in some of these women. Medications in pregnancy, they may be appropriate and they may be pretty safe. Each woman needs to evaluate this situation with the help of the doctors and carefully weigh the risks and potential benefits in her own individual circumstances, looking at the balance of what happens to a fetus if the woman is not treated. In the postmenopausal aging women population, depression is more common, more issues of loss, but also maybe running out of some of the transmitters in the brain and need to treat that as well. If you or someone you know might be experiencing a mental illness or emotional problem, please help them get professional help while you give them support that only the family and friends can actually provide. Talk to your doctors, and I agree certainly with you, Lee. We want to make sure patients go to good websites to get more information. We're going to highlight again your site, womensmentalhealth.org, healthyminds.org, NAMI.org, NIMH.org, and for all of our listeners, we want to say thank you for tuning in. Thank you again, Dr. Cohen. Next week, we'll be discussing eating disorders with Dr. Robin Cezanne. For Psychiatry, Ask the Expert, Dr. Kaye and
Jay Birch,
saying we'll see you next week. Bye-bye.
Thank you for listening to Psychiatry